Hey everybody, welcome to our lymphedema class. My name is Trevor Lohman. I will be your teacher for this short introductory video, as well as our two lab classes. I guess we have one lab with two different groups. So I'll try to make this as interesting as I can. Online is tough. It is pre-recorded, so if you want to just lay down, close your eyes. No, don't close your eyes actually, because there are photos. But just relax. This is going to be an overview. I'll review a lot of this in our lab, but I can't make any assurance. I'm not going to go through it as systematically, so please make sure you watch the video, especially for the test questions. I'll try to keep it short. I'll try to keep it to about 30 minutes. You will have another 30-minute video, and then you'll have some lab videos as well. I'm getting ahead of myself a little bit. So my name is Trevor Lohman. My day job, I'm a regional therapy director. I'm actually a regional director of operations now, is my current title, for 20 licensed home health agencies in California, Oregon, and Colorado. So I do a lot of traveling, or at least I used to. And my interest in lymphedema actually came about through that role. As a regional director for a home health company. You'll find when you graduate and get into the field that lymphedema is an interesting diagnosis, but there's an interesting almost kind of mythology surrounding lymphedema, and a lot of that mythology has unfortunately penetrated the Centers for Medicare and Medicaid Services, which influences payment, even if it's a Blue Shield insurance. A lot of these guys, private insurers sort of follow Medicare's guidance. So Medicare sort of lays the groundwork for lymphedema reimbursement. And there's a lot of patients out there who need services, but navigating the payment issues can be kind of tricky. So anyway, I got into lymphedema because that's sort of my specialty, insurance reimbursement and utilization management and various factors. I've ran a clinic, I've done outpatient ortho private practice. I've ran a few other businesses related to physical therapy. Anyway, so that was kind of my thing. So we had all these Medicare patients up in Medford, Oregon, actually, that couldn't be seen. The reason they couldn't be seen is that other agencies wouldn't take them because Medicare doesn't cover lymphedema. So anyway, we figured out a way to make it work so we could provide care to these patients. And a part of that process was getting certified. So I was fortunate enough to go get certified. It's a $4,000 deal. It's 135 hours of coursework. It's 12 hours a day for 7 days in person, and 7 a.m. to 7 p.m. for 7 days. And then there's, I think, like 40 or 50 hours of online coursework. So it's pretty extensive. My work paid for it. It was great. And I was interested in it. And around the same time, my mother-in-law was diagnosed with breast cancer, and there's lymphedema concerns with that, of course, with lymph node removal and cancer treatment in general, radiation, chemotherapy. So I continued to get into it. And then at the same time, I had started on the side, kind of like a side thing while I was working. I had started an outpatient clinic with a good friend of mine who I worked with and my father. And at the time, it was pretty early on. We were doing okay. We were struggling with all the entrenched referral sources in Redlands, and we kind of wanted something to make us stand out and be different. And so we actually were approached by the Loma Linda Cancer Center and some folks from Redlands Community Hospital to open a lymphedema clinic. And we were a little resistant just because it was sort of an outpatient sports ortho type clinic, but we sort of carved out a separate area of the clinic for lymphedema patients, and it worked out. Actually, we filled a niche, we filled a huge need. So we got super busy. It's a little bit easier to bill for lymphedema services and outpatient. It actually turned out great. We ultimately sold the clinic, which is kind of a good and bad thing. And there's parts of it I miss, but it was nice to sell. And so I'm not in the clinic treating lymphedema patients anymore. I do some occasional trainings at work. I've probably treated hundreds of lymphedema patients in outpatient, and probably hundreds in subacute as well. So I know this stuff. I'm not currently practicing anymore. At this point, I'm mostly just teaching a lot of different classes as well as traveling for work. Even though I'm not treating anymore, though, I'm feeling pretty confident I can get you guys up to speed, which brings me to my next point, and that is that this class is definitely an introduction. You have to be certified to treat lymphedema patients. And I say have to kind of loosely. I mean, if you treat a patient with lymphedema in a skilled nursing facility, the PT board's not going to kick down the door and arrest you or anything like that. There's no, it is technically within your practice act. The issue is that typically most physicians will not, or not even physicians, I mean, most patients' family members are going to expect that you're a certified lymphedema therapist. For whatever reason, it just has that, I don't know what it is. If you're an OCS, you wish you could inspire patients to seek out orthopedic clinical specialists the way that lymphedema patients seek out CLTs. I don't know what it is, but you will find that realistically, you probably will not be treating lymphedema patients without this certification, maybe once in a blue moon. My goal here is, in this class, is to give you enough information so that you don't do anything too wrong. If you do sort of stumble into a situation where you're asked to treat a lymphedema patient, most likely you're probably not, you won't be proficient at lymphedema management, and therefore you probably shouldn't be the therapist assigned to that case. But a lot of times you might see a lymphedema patient passing through. You might be in the hospital and you might be with them for a day or two. And you want to be able to give them some basic information and do some basic treatment. So that's the goal. I don't expect that any of you will be doing any wrapping or anything like that. So I'm going to introduce you to all of it just in case. I'll try to give you kind of a 30,000-foot view. And really, I'm hoping maybe I can pique some interest in some of you guys, and you might want to give this a try. It has a little bit of a stigma. You think of lymphedema and you kind of think of sick patients in the skilled nursing facility. That's not the case at all. You'd really be surprised. In the U.S., we'll talk about this later, but most of your patients are going to be middle-aged women who've had breast cancer, and cancer treatment is now over. Maybe they went into remission. They could currently have cancer, but most likely their treatment's concluded. And of course, you don't really ever say that you're cured of cancer, but they're at least in remission. And, it's been 6 months, a year, 5 years, 10 years since they've had cancer treatment, and all of a sudden they have some arm swelling. And so they're there to see you, and you can actually make a huge impact. Really. That's one of the cool things about lymphedema. I don't know if you guys, I think you're year 3, so you've had the BPPV class, the vertigo class. That's another really exciting thing that you can do, a 15-minute treatment and change a patient's life. Lymphedema is kind of the same thing. Sometimes they come back to the second visit, and you're the first person in years that's been able to help them. So it's fun. All right. I did not mean to talk that long. Let's get going. You'll probably hear all of this again in lab. I apologize on my introduction. Okay, so what is the lymphatic system? Hopefully you guys know. Hopefully you've heard of it. But in case you haven't, I'm sure you're all very familiar with your circulatory system, your arterial and venous systems. The arterial system moves blood away from your heart to your body's tissues, to the capillary beds, and the venous system takes blood back to the heart. Now, this is a circulatory system, and what I mean by that is there's no start and stop point of the circulatory system. It's a circuit. It's a loop. It's not technically a closed loop. Fluid can leak out of capillary beds and does, but it is a loop. The lymph system is a little different. The lymph system has a starting point, and it starts at the lymph capillaries. That's why they're called the initial vessels. We're going to look at a slide right after this, or in a couple slides, that talks about lymph capillaries. Those lymph capillaries coalesce with other capillaries and form larger and larger vessels called lymph collectors. Those lymph collectors deliver lymph to regional lymph nodes. And the lymph nodes, from the lymph nodes, the lymph travels two lymphatic trunks, the biggest of which is called the thoracic duct. It's a huge, it's where most of your lymph fluid returns to your heart. It returns to venous circulation in the subclavian vein, and it returns about 2 liters per day. Now, what is all this fluid? Where is it coming from? Well, the fluid is created in the lymph capillaries. So these lymph capillaries, if you see, this structure here is considered a lymph capillary. And the next slide even has a better picture. And they're here to collect fluid that is leaking out of these capillary beds. So you have the capillary bed, and blood is rushing into the capillary bed to deliver oxygen and nutrients. Well, some of that fluid leaks out, and it's designed to. If you've ever walked around Disneyland, for 8 hours and your hands and ankles are kind of swollen up, that's fluid that's leaked out of your capillary beds into your tissues. It becomes interstitial fluid. You have a system designed to remove that fluid, and it's actually not the veins. Some of it will return to venous circulation, but a certain amount of it cannot return to venous circulation because it's rich in proteins and immune cells and all different sorts of things, lipids in some cases. So it returns through lymph capillaries, and lymph capillaries are at the start of the lymph system. That brings me to what is lymph. So this is a better picture to explain what I was just talking about. So here we have a little capillary, kind of a funny looking capillary, and there's little gaps between these endothelial cells. So this is kind of a typical peripheral capillary. You wouldn't, the capillaries don't look like this everywhere. They don't look like this in the brain. They don't look like this in the spinal cord. But out in the periphery, in your tissues, in your limbs, in your thorax, capillaries are pretty leaky. Stuff leaks out of them by design. Now, what determines how much fluid leaks out of a capillary? Well, that's what this first bullet point is here. Hydrostatic versus osmotic pressure. So I don't want to go too far back to, undergrad biology, but basically the water pressure force pushing fluid out of the capillary is hydrostatic pressure. So on a molecular level, these water molecules are bumping into each other, and water pressure is exerted on the walls of the capillary, and water leaks out. It's not just water, it's plasma. It's blood plasma leaks out due to the water pressure, in quotes. Hydrostatic pressure is the better term. There's another force preventing water loss, and that's osmotic pressure. Sometimes it's called oncotic pressure. Basically, there are proteins dissolved in the blood, and that creates a concentration gradient for water. Water is attracted to these proteins. So these two forces are at odds with one another. It's an equilibrium. So osmotic pressure is pulling fluid in. Hydrostatic pressure is pushing fluid out. In the capillary bed, hydrostatic pressure is winning. So fluid is leaking out of the capillaries in a normal situation. Some of that fluid will return to venous circulation. Venous pressure is lower, so fluid can leak out of the tissues back into the veins, but not all of it can. There's a lot of proteins dissolved in the fluid here in the tissues. There's immune cells in the tissues. Those can't return to venous circulation. So that's where the lymph system comes in. This is a lymph capillary. So they've drawn these little cells. You see this line? They're trying to show you that this is a cell right here, okay? It's an endothelial cell within the lymph capillary. Check this out. We have these little overlaps. Okay, let's just look at these two. If pressure outside the lymph capillary is greater than pressure inside, which it almost always should be unless there's a problem, fluid will leak into the lymph capillary. It's the cells overlap in such a way where that occurs. If for some reason the situation was reversed, fluid can't leak out because it will actually close this valve. So it's a one-way valve. These overlapping segments of endothelial cells in the lymph capillary create a one-way valve type of situation. Okay? And so basically, as long as pressure is higher in the interstitial fluid, fluid will enter the lymph capillary. As soon as fluid enters the lymph capillary, it becomes lymph. So if you hear the term lymph production, you might think of like a cell releasing proteins and making something. That's not the case. You make lymph. It's kind of a weird way of saying it. You make lymph as soon as interstitial fluid enters the lymph capillary. That's what lymph is. It's just fluid within the lymph system. Okay? It is high in proteins. It contains immune cells. There's lots of solutes. It's all of the stuff that couldn't get back into circulation and enters the lymph capillary. Now, if you guys see, there are these structures here. These are called anchoring filaments. They're attached to collagen fibers in your tissue. By the way, most of your lymph capillaries are within your areolar connective tissue, right under your skin. Well, it's technically a part of your skin, but it's about 1 millimeter below the surface of your skin. Anyway, sorry for the tangent, but these anchoring filaments here, if tissue pressure increases within the tissue, they actually pull open these gaps even more than usual. And that causes even more fluid to enter. So you kind of have this really interesting pressure-sensitive system for collecting fluid and producing lymph. Okay. I know I'm talking fast. Don't worry about it, guys. We'll keep it basic. When we get to lab, I'll make sure you know what's important, okay, for the test and for life in general after graduation. So I'm just going to give you kind of a fast rundown here. So if you're feeling like I'm going too quick, don't worry about it. Just try to relax and conceptualize it. Okay, so we've talked about how lymph is produced. It enters lymph capillaries. Lymph capillaries are the start of the lymphatic system, the system that brings lymph or fluid from the periphery, from your peripheral tissues, back to circulation, back to your heart where it can be distributed again. Okay, so how does it move? We know how it forms. We know how lymph is produced. It enters the capillaries. How does it move? Well, your lymph collectors have these things called lymphangions. Lymphangions. So this is a lymphangion here. Okay, this little guy. And there is a wall, and I believe that's what they're showing in red here, of smooth muscle within each of these. And it's innervated by the autonomic nervous system. So these lymphangions demonstrate something called lymphangiomotoricity. That's a $2 word right there. That's exciting. Lymphangiomotoricity. Anyway, so these lymphangions contract and they move fluid. Okay, and what's interesting about them is they have one-way valves. So if this were to contract, it doesn't need to push fluid in a particular direction because as soon as pressure goes up here, this valve shut. You know what? I should have done it. I should have done the one next to it. Sorry, bear with me. So let's say this one contracts here. That opens this valve and pushes fluid this way. And then when this one contracts, this lymphangion contracts, it's going to close this valve because this is a one-way valve and it's going to push fluid this way. It's going to open that valve. So you have this system for moving fluid in one direction, back towards the heart. Here's the deal. This actually does not move that much lymph. Your lymphangions cannot move that much lymph on their own. You need some help, and that help comes primarily in the form of a muscle pump. And you guys probably learned about muscle pump at some point, talking about venous circulation and venous return, I think. I vaguely remember that from PT school. So the same thing applies with your lymph system. The muscles are moving around under your skin. That squeezes against these lymphangions, and that pushes fluid. It doesn't matter which direction the muscle is bumping up against this lymphangion because it has one-way valves. So as long as some pressure is exerted on the lymphangion, fluid moves towards the heart. These are also the structures we're acting on when we do manual lymph drainage. We're trying to stimulate these structures by just really lightly massaging them, basically. It's not like, what's it called? I remember Dr. Bruce Bradley taught it to us. Oh boy, that's not good. But you're doing massage to reduce edema, and you're clearing the proximal section, and then you're doing the distal section. And that's pretty forceful. You're actually trying to push fluid out of the veins. This is a little bit different. Your lymph system, again, is about 1 millimeter under the skin. So you'll see that the massage is pretty light. But anyway, that's one of the structures we're working on. We're working on these lymphangions, and we're trying to increase lymphangiomotoricity. So what is lymphedema? This slide is a joke. I just copied and pasted a long definition from somewhere, kind of as a joke. Even though it is a joke, though, I'm going to kind of read it because it does highlight one important aspect of lymphedema. And then I will give you an actual simple definition of lymphedema. So what is it? So when a disorder of lymph drainage develops, so basically when you're unable to pull lymph out of your tissues at a fast enough pace, protein-rich fluid accumulates in the tissue. That's key, protein-rich fluid. Because here's the deal, plasma, just water, basically, with simple solutes like sodium and glucose, they can return to venous circulation fairly easily. It's these large proteins that can't. So what happens is if the lymph system starts to fail, you get a very protein-rich environment in addition to tissue swelling. So the interstitial amorphous ground substance swells, which is a fancy way of saying the tissue begins to fill with fluid and proteins. As with chronic inflammation, increased amounts of mononucleated inflammatory cells, such as monocytes, migrate into the edematous area. What's important about this? It's just pro-inflammatory. Okay, so we're going to get a lot of monocytes and a lot of macrophages. They release pro-inflammatory cytokines. So with inflammation comes more blood flow and more fluid to the area. So we already have a protein-rich environment with tissue swelling. Now we're going to add more water to the mix. It's not technically water, but you get what I mean. We're going to add more fluid, blood filtrate, plasma, water, solute, sugars, proteins, all that stuff rushes into the area. So now we have this protein-rich edema. Now what do we know about proteins? Proteins are necessary for cell growth, or tissue growth, rather, sorry. So we have this protein-rich environment characterized by secondary tissue changes. We have lipoperoxides, which attract defense cells. We have macrophages secreting cytokines that are inflammatory and stimulate fibroblast production of collagen. So now we have connective tissue proliferation and fibrotic changes and fatty degeneration. What is all this saying? Well, basically it's saying that we have an environment ripe for connective tissue proliferation. So we have collagen fibers, which are tough and fibrotic. That's what fibrotic means. And we have lipids in the area. So now we have this fatty, fibrotic, protein-rich environment. No good. Actually, by this point, lymphedema treatment is not that effective. So hopefully you can catch it before this stage. So the macrophages are releasing signaling substances which stimulate more fibroblast mitosis and more connective tissue proliferation. Some fibroblasts transform into fat cells, and this is kind of once you're into the fibrotic stage of lymphedema, which is, I wouldn't say irreversible, but much more difficult to reverse. Okay, I'm trying to paint a picture that basically lymphedema sets you up for swelling and fibrotic changes to the tissue. So if we can catch it in that early stage where it's just mostly swelling and it's a protein-rich fluid, but there's no changes to the tissue, we can reverse it. And don't let anybody tell you otherwise. You'll get sometimes you get some eye rolls about lymphedema. I know that because I started off doing ortho and had private practice. Lymphedema was kind of this like, oh, brother. That's just really not the case. I mean, my experience is with secondary lymphedema, which is the most common type and what you'll most likely be exposed to. It's very reversible. Very reversible. You can fix it. So you can take a swollen limb and return it to its normal size. Unfortunately, the patient has to wear some kind of compression for the rest of their life, which is tough for them. And you may well be the first person to tell them that. if you become a lymphedema therapist. But the good news is you can really transform people's lives. So it is fun, as long as it doesn't get to this late fibrotic stage. Okay, so what's a simpler way of describing lymphedema? When lymph production levels fall below what is necessary. So this is kind of oops, I didn't mean to do that. This is kind of counterintuitive sounding because you think as lymph is bad, kind of, when you're thinking about lymphedema because you're trying to get rid of fluid. But remember, lymph production means the fluid is leaving the tissue and entering the capillary. So it's actually a good thing. It means that you're pulling fluid out of the tissues. So anyway, what is lymphedema? When lymph production levels fall below what is necessary to maintain normal tissue pressure and volume. I made this up. This is, to me, the most simplistic understanding of what lymphedema is. I will modify this to differentiate it from edema to just include maybe like normal what am I trying to say? Normal concentration of protein within the interstitial fluid or something like that. But essentially, I mean, the issue is that we have extreme swelling in a limb because lymph production is low. It's different from edema because the issue is specifically lymphatic in nature. It's not venous insufficiency. It's not a problem with the venous system. It's a problem with the lymph system. So that's what differentiates lymphedema from edema. Lymphedema is typically one-sided. You can have bilateral lymphedema, but typically it's unilateral. It's protein-rich fluid. It's progressive, and there is no cure. There is a very effective treatment if caught early, but there is no cure. And here's an example of someone who's caught pretty late. I mean, I can guarantee you there are some fibrotic changes in this individual. If you were to squeeze that left leg, you'd be met with a lot of resistance. It wouldn't feel like a fluid-filled leg. It would feel like a fibrotic, collagenous leg with adipose and with fat. So this was caught pretty late, and you can see it's almost full restoration. But once you get fibrosis, you never get 100% recovery. And you can see in this case, even though it looks significantly better, the after picture, it's not complete recovery. So you can especially see it in the ankle and the foot. All right. So, I do want to mention right here, there are two types of lymphedema, which is what the next slide is going to talk about. This is an example of primary lymphedema. Now, primary and secondary lymphedema don't necessarily look different. The deal is how you got it, how it came about. So primary lymphedema is inherited. It's genetic. It's often congenital, but it isn't always. Milroy's disease is congenital. And then there are other versions that it can show up in puberty or pregnancy or even after 35. All of these are genetic disorders resulting in some sort of inability to produce enough lymph. So whether it's some type of congenital malformation of the lymph capillary at birth or something that happens later in life. The deal is it's genetic. That's what primary lymphedema means. It's inherited. Now, unrelated to this slide, but I do just want to point out, we'll talk about this more in lab, but you can see there are some little blisters, or I'm not sure exactly what's going on there. Lymphedema can get pretty nasty. I hate to say it. It can get a little gross, especially with non-cancer related patients. Cancer-related patients are typically middle age, and they're coming to you after finishing chemotherapy and radiation, so it's new. Maybe it even hasn't started yet. In some cases, their oncologist is just being cautious, and you won't see a lot of this. However, if it's an issue of ignoring treatment, so non-compliance, if it's an issue of some kind of infection or trauma that caused lymphedema and it went untreated for some time, you can get some pretty weird stuff. I actually had a patient one time whose arm was, as a man, literally dripping while he was talking to me. So that's the kind of stuff I didn't particularly enjoy. You might be more adept at that kind of thing. But anyway, I just brought that up because I saw these are like little fluid-filled pustules, or I imagine. So what is secondary lymphedema? Secondary lymphedema is lymphedema that is not inherited. Typically a result of cancer treatment, breast cancer being the most common. There's very likely to be lymph node removal with breast cancer. My mother-in-law, for example, had 20 lymph nodes removed from her, I believe, her right arm. I can't remember. So you can imagine with direct damage to the lymph system, you may have some increased difficulty transporting lymph. Chemotherapy is toxic to various parts of the lymph system, and so is radiation. So all of these things can cause a decreased ability to produce lymph. So can other surgeries. Liposuction, for example, has a tendency to cause lymph damage, lymph collector damage. It can also be caused by a parasitic infection. This is the most common cause of lymphedema in a lot of other countries. There are nematodes, parasitic nematodes that actually reside in and do damage to the lymph system. And it can be caused by other traumas. I had a patient who broke their leg as a kid, and 10 years later, they developed lymphedema. It's kind of crazy. And I can explain why that is in class if someone can remember to ask me why it can be late onset. Anyway, this most likely is what you're going to be dealing with. This would be kind of a typical patient. For the most part, the patients I saw were actually even a little bit earlier than this because we had a really great oncologist at the medical center that just referred everybody to us. So a lot of times we were just doing preventative, which is the best for the patient especially. They never have to see this happen to them, and they never have to experience the long-term fibrotic changes in their skin. So I wouldn't expect you to see many patients more advanced than this, unless you are operating a lymphedema clinic with, renown in the region. So you have difficult cases coming to you, which would be very cool. And I would be so excited if any of you did that. Reach out to me in 5 years if you decide to do that. I'd love to hear about it. But most likely, if you're just seeing overflow from a hospital or outpatient private practice lymphedema, this is kind of your typical patient. Okay, so what kind of treatments are there? I should have given you a trigger warning. This picture here is kind of bad. I put no good here just in case someone ever saw this PowerPoint without the video, because without no good, it makes it look like I'm saying these are the treatments. No, these are not the treatments. So let me go through this. Debulking. Debulking is what you see here on the right. There are less extreme examples than this, but generally speaking, debulking does not work. It actually makes it worse often. So what they do is they go in and they remove the fibrotic, adipose infiltrated, collagenous tissue, this protein-rich tissue with fibrotic changes and keratinosis on the skin. They go in and they debulk it. They remove the tissue. Now, of course, that means they're removing the lymph structures as well, and the result is almost never good. You can see, though, that they've maintained the size. I don't know how long after the surgery this picture was taken, but I mean, look at the skin. It does not look well. So, as you might imagine, this is not done often anymore. At least here, maybe done more in other countries. I don't know. Oh. Excuse me, I shouldn't yawn. It's late right now. For me, it's midnight. This is when I get all my work done. Anyway, so debulking is not good. Now, this next one is probably the most important one, and realistically, this is the most likely applicable thing for all of you, because well, let me just give you an example. I told you I run a bunch of home health branches, and sometimes I'll show up for a case conference just to say hi to everybody, keep in touch with all the therapists and the clinical supervisors and the directors and everything. So I'll just show up for a case conference. And I would say about 1 times out of 10, there's a salesman selling lymphedema pumps. And I'm always so conflicted because this is just some salesman. They're not a clinician and operating on commission for the sales of these pumps. And there's about, I would say, 90% of me that just is like, let this guy do his job. Don't ruin his day. But then there's like a part of me that says, you know what? No, I should say something because these are not good for patients. So basically these pumps, they do segmental compression. The good ones do segmental compression, and the idea is that they would push fluid back to the heart, which makes a ton of sense. I mean, on the surface, the reality is they just don't tend to work, and they can even damage lymph collectors. So the real problem with this isn't that they don't work that well, it's that they prevent you from getting the actual treatment that does work. And as we've learned, this is a progressive disease, and once you cross that fibrotic threshold, you start to get long-term tissue changes. So I do not recommend this, and I encourage you to not recommend it to your patients. So usually I wait till the salesman leaves, and then I say, hey, everybody, by the way, I don't know if you know, I'm a CLT, and you should not order these for your patients. They're super expensive too. Okay, so no debulking, no pneumatic pumps. That is the take home. Magic lymph massage. This is probably the least dangerous of all these. The problem is it doesn't really work either. You will run into folks, sometimes even certified lymphedema therapists, I hate to say it, who are way into the manual lymph drainage component of the treatment program I'm going to introduce on the next slide, and not so much into the compression bandaging component of CDT. I don't know why. I mean, there is the issue of you can't actually bill for both. I don't think that's it. I just think there's this. I just think as a PT, you just have this inclination to feel that the more manual therapy component, the hands-on component, is going to be more effective, and it is effective. But the compression component is critical. I would say 90% of the results we get, I'm making that up. Other CLTs may disagree, but just anecdotally, what I've seen, the compression component is 90% of the game. And it works because it's graduated compression and it's 24 hours a day versus a pneumatic pump, which is just kind of like wringing out super high pressure one segment and then super high pressure the next segment, and then you don't wear it at all for hours. The compression is key. Compression bandaging and compression garments are key. So if you see someone who's doing a lot of lymph massage but no compression, that's probably not good either. Lymph diets. So different folks recommend different things. Generally speaking, though, there is no diet for managing lymphedema. You'll see a lot of folks talking about low sodium diets. That may be, interesting. Low protein diets, potentially. There's really no evidence that I'm aware of, at least not the last time I looked when I became certified about 3 years ago, that there is any particular lymph diet other than just a generally healthy diet. Obesity complicates lymphedema. So eating healthily is important, but there's not really a specific lymphedema diet. You will see some recommended in books and things, but not scientific books, just like lymph books from lymph patients and stuff. Just eat healthily. That would be the recommendation. And then the most dangerous, probably, other than maybe debulking on here, is fluid restriction. So some folks will recommend fluid restriction. I've even seen physicians recommend fluid restriction. That doesn't do anything for you. That does not help you one bit. In fact, you may even have low blood pressure because so much fluid is draining into your limbs. So then you go and dehydrate yourself, and that's no good. So no fluid restriction. So last slide. What does work then? Well, complete decongestive therapy is the current gold standard in the world. And PTs are well suited to be the practitioners to deliver this. OTs do it as well. I think even massage therapists can be certified. There's the issue though of billing. Obviously, with if you're a PT, you can bill insurance and Medicare. That's more difficult as a massage therapist. Nurses, I've seen nurses do it. A lot of times you'll see a nurse who's like a wound care certified and lymphedema certified nurse. That's incredible. If you're one of those, or if you're a PT who's wound care certified and lymphedema certified, you will be a hot commodity. Just because there's not that many people who do that. So you'll be the one for the whole hospital, and they'll be begging you to work overtime. Anyway, so complete decongestive therapy is the gold standard. It's a 2-phase process. Both phases are composed of the following: compression therapy, manual lymph drainage, exercise, and skincare. Again, my personal emphasis on my personal opinion. This isn't for the sake of a test or to just tell other lymphedema therapists that what they're doing isn't important. Because in my opinion, compression therapy is where you are going to see the most impressive gains. You'll have very quick reduction in limb size and prevention of the symptoms coming back with compression. That said, that reduction and prevention will be enhanced with manual lymph drainage, with exercise, and then regardless of everything, you need to do skincare. Now, the reason for skincare is that when your limbs swell, all of a sudden, your cells within your tissue and your tissues, regions of your tissue becomes farther away from the capillary. That's especially true for your skin. The nutrition supply to your skin and most importantly the white blood cell supply. Now, white blood cells don't move through the skin to the upper layers, but the dendritic cells do, which is a component of the immune system. So basically, the point I'm trying to make is that you're at a much higher risk of infection. So proper skincare is important. Also, that your skin can dry out very easily, and dry skin can lead to increasing the likelihood of a wound, and a wound with lymphedema is bad. And you're much more likely to get a wound when you have lymphedema, so skincare is very important. So anyway, so back to what I was saying, 2 phases, phase 1 and phase 2. This diagram over here, this is like the standard diagram for CDT, and it is terrible. I don't like it. It's confusing. So I'm going to break it down really simply. Phase 1 and phase 2 are essentially the same with 2 important differences, and really only 2 important differences. So phase 1 consists of compression bandaging, manual lymph drainage performed by the therapist, exercises prescribed by the therapist, and skincare recommended by the therapist. Phase 2 is a compression garment. So that's a big change. We went from compression bandaging performed by the therapist to the wearing of a compression garment. Okay, so that's the big difference between phase 1 and phase 2. So during phase 1, you're wrapping the limb with bandages. You're shrinking the size of the limb. They come back every couple days. They don't go more than a couple days without seeing you. And you rewrap the bandages tighter and tighter and tighter until the limb is back to normal. Then you're in phase 2. You fit them for a compression garment. They wear that compression garment forever, all the time. And that keeps it from coming back. That's phase 2, maintenance. All right, so anyway, the other difference is the lymph drainage. So during phase 1, you do manual lymph drainage as the therapist. During phase 2, you can teach self-lymph drainage. Honestly, if you have a well-fitting garment and they reorder them routinely so that they don't lose their stretchiness, it's not as important personally. That's a controversial thing I'm saying in the lymphedema community. However, technically, this program, Complete Decongestive Therapy, calls for the patient to do lymphedema drainage on themselves during phase 2, during the maintenance phase. So they take their sleeve off for a bit, and they do these lymph drainage exercises, and then they put the sleeve back on. And then the patient does exercise. It's a very specific form of light exercise. We'll talk about that in lab, and skincare. So the big differences between phase 1 and phase 2 are these first two. Oh, I thought I had the highlighter. Sorry. Are these first two. Okay. Again, in phase 1, you're doing compression bandaging. The bandages are changed every couple days. And in phase 2, they're wearing a compression garment. In phase 1, the therapist is doing manual lymph drainage. In phase 2, the patient's doing it because they're at home. They're not seeing you anymore. You fix them. So phase 2 is the patient maintaining the gains that you've made during phase 1. And guys, that's it. So if you're thinking, man, that was quick, well, you may be thinking, man, that took forever. I don't know. But if you're thinking that was quick, don't worry. This was just a really quick introduction. I want you to watch, there's several more videos, not several, there's a few more videos in this module. The next one is by a guy, I believe his name is Gunter Klaus. Gunter Klaus, best German name ever. You'll find most of these lymphedema experts are German. Germany is a big, for whatever reason, that seems to be where all the compression garment companies are and all the experts are. Anyway, he's going to walk you through what CDT is in a little bit more detail. The video is an hour and 15 minutes long. You only have to watch up into the Q&A, which is only about 30 minutes of video. Feel free to watch the Q&A. It's very explanatory, actually, so I'd encourage you to do so, but you only have to watch the first 30 minutes. And then there's a couple videos on wrapping and measuring for garments. So please watch all of that before our lab. Okay, so I don't know what group everybody's in, but our first lab is on October 29th. You'll come in, I'll show you a little bit of manual lymph drainage, not a ton, because I want to use most of our session to kind of review some of the stuff we talked about today, but to have you guys practice bandaging. You will probably in your career, if you work in an acute or a subacute setting, maybe not an outpatient, but if you work in an acute or subacute setting, you're going to come across a patient with lymphedema, and nobody's going to know what to do. So say they're in the hospital for a few days and they have lymphedema. Maybe they were admitted for lymphedema, or maybe they're in a skilled nursing facility with lymphedema. No one is going to know what to do. And if you can remember how to wrap, I'm tentative to say that because if you're not careful, you can do more harm than good. But you can maybe go back and watch a YouTube video about wrapping or something. If you can remember how to wrap and teach the patient how to wrap, you are going to improve their treatment course so much, because once they get out of that sniff, eventually they're going to need to seek a certified lymphedema therapist. And if that patient is self-wrapping, or if you can get them a garment that's adjustable even, you're really going to change their outcomes. You're going to delay that fibrotic portion of this disease process. So if I can get you guys to do some wrapping and do a good job wrapping, and remember, 50% of it enough so that you could rewatch a YouTube video to figure it out. And if you can remember some of the basic characteristics of lymphedema, the types of things to avoid while wrapping, the types of things to avoid while doing lymph drainage so that you don't do more harm than good, I'll be super happy. So if any of you are wanting kind of like to be a lymphedema expert, unfortunately, that's not really what this class is. You do have to do the certification. But I'm going to do my best to teach you as much as I can in 4 hours, okay? So watch the rest of the modules. If you're watching this and you're having some questions that need to be answered before our class, my email is tlohman, so TLOHMAN @llu.edu. You can email me, ask away. Happy to help, and I'm looking forward to meeting you guys in person. Take care. Bye.